I welcome you all to this very important webinar presentation today, that is on tibial plateau fractures. I am Dr. Rajesh Goyal. I am Professor and Head, Department of Orthopedics, Medical College, Kota. I have been former President, Rajasthan Orthopedic Surgeons Association. I have been former President, Central Zone of IOA. I have been member of Executive Committee. I have been member of PG Teaching Committee, and I have been member of Research and Publication Committee of IOA. I am also the chief of the trauma center present over here in our medical college. So the tibial plateau fractures, as you know, it is often associated with high velocity trauma. It may have severe intra-articular comminution. It may be associated with neurovascular injury, compartment syndrome, and deep vein thrombosis. There are added morbidity as well. There are overlying skin injury, ligamentous injury, and the meniscus injuries. The prognosis is guarded most of the time because there may be some chronic pain, there may be some restriction of the movements, and there may be some post-traumatic osteoarthritis. So this is the broader anatomy of the knee joint, which is showing in the AP view, the tibial condyles as well as the femoral condyles, the ACL, and the patella. In the superior view, there are the menisci, which is visible, the medial condyle and the lateral tibial condyle, and the posterior view, which is showing the attachment of the fibula to the tibia, which is showing the articular surface as well as and the soleal line and the posterior lateral surface. So the another important slide about the anatomy, the medial condyle is slightly concave in shape and the larger in both width and the length. The cartilage thickness is 3 mm. While the lateral condyle is convex, it is 2 to 3 mm superior to the medial condyle, and the cartilage thickness is more, that is 4 mm. The medial proximal tibial angle is 85 to 90 degree, and the posterior slope, which is very important to know, that the posterior slope is 9 degrees, and both plateaus are covered with the hyaline cartilage. Most of the time, the mechanism of injury is the valgus force. There are 3 types of injuries in the tibial condyle fractures. The most common is the valgus force. The person is being hit by some vehicle from the lateral side, and there is a fracture. Then another mechanism is valgus and the increasing axial compression. While the person is walking and being hit by from the lateral side or from the lateral aspect of the condyles, the lateral aspect of the leg bones, then it leads to split depression fracture and the lateral side depression fractures, and less commonly also lateral split or the total lateral condyle fractures. Then another important fracture which is more comminuted is high axial load. Somebody when he falls from the height, then it leads to bicondylar pattern of the fracture. Another important aspect of this mechanism is the posteromedial fracture of the medial tibial plateau is sometimes we can see, and it's a common medial pattern. It can be isolated split fracture or part of the bicondylar fracture. So this is the forces being generated from the lateral side, the valgus force, the axial load, as well as the high axial load and increasing axial compression. So let us know the classification. Why we go for classification? The classification is very important because it helps us in planning and the management of the fracture. The most common classification is Schettker classification. Another is AO or OTA or Orthopedic Trauma Association classification. And the latest one is the column-based classification. Schettker classification is the most popular one, and everybody is being used to this type of classification. The Schettker type 1 is lateral tibial plateau fracture. In this case, there is no depression. Mind it, there is no depression. There is a wedge-shaped comminuted fragment, which is not uncomminuted fragment, which is split off and displaced laterally and downward. It is very common in young patients, and mind it that the lateral meniscus injury may be common in this type of fracture. Schettker type 2, lateral tibial plateau fracture with depression. You see the difference between first and second is that in second type, Schettker type 2, there is a depression fragment which is lying there. So we have to mind it that we have to observe it, that this depression has to be recovered. This depression has to be completely covered. Then otherwise there will be incongruence of the articular surface. Schettker type 3, there is purely a depression fracture, compression fracture of the lateral condyle or the central tibial plateau. It's purely depression of the lateral articular surface only. It is very common in elderly because the bones are osteoporotic. Yes, this is a Schettker type 4, which is very, very severe type of injury. That's a medial tibial plateau fracture. It may split off as a single wedge or it may be comminuted and depressed. The tibial spines are oftenly involved. and it may be associated with ACL and PCL injuries as well. So the medial tibial plateau fracture is further classified by Mark Weckist, and he has given the 3 types of classification in the type 4 of the Schettker type. One is the fracture line passing through the medial to the tibial spine. Another is fracture line passing through the tibial spine, and third one is the fracture line passing through the lateral to the tibial spine. Why this is important? Because in type A and type B and type C, as we go from type A to type C, the neurovascular injury chances are increased, the severity of the injury is increased. So the type A is very mild type, while the type C is very severe type, and there may be severe neurovascular injury as well. Schettker type 5, bicondylar tibial plateau fractures, in which both the condyles are injured. It may be associated with the fracture of the fibula as well, and but the diaphysis is still retaining the continuity. Mind it, the diaphysis is still continued, while there are 2 tibial condyle medial as well as the lateral tibial condyle fractures. Schettker type 6. The difference between type 5 and type 6 is that in this case, the diaphysis continuity is not maintained. Rather, the diaphysis is also fractured along with the fracture of the medial condyle as well as the lateral condyle. The AO or Orthopedic Trauma Association classification, they have simply classified in the type of non-articular, articular, or partially articular. But this does not give us complete information what type of fracture it is, how should we plan, how should we manage this fracture, because if we do not plan properly, if we do not manage properly, the chances of complications are very, very high. So the 3-column classification, first of all, it was given by Kong Feng Lu, and this is a very important classification because it encompasses all the structures, all the parts of the tibial condyle, and it gives us very good picture for the planning and management of the tibial condyle fractures. There are 5 points. These 5 points can be joined together, and we can divide these tibial condyles into medial condyle, medial column, the lateral column, as well as the posterior column. Part 1 is the center of the intercondylar eminence. Part 2 is the anterior tibial tuberosity. Third is the posteromedial ridge of the proximal tibia. Fourth is the most anterior part of the fibular head. And fifth is the posterior sulcus of the tibial plateau. We join all these 5 points together, and we find that we'll get medial column, lateral column, and the posterior column. So this way, we can very well plan where is the fracture, where is the fragment displaced, and we can plan and we can manage the things. So these 3-column classification, if we correlate with the Schettker type thing, then in the 0 column, Schettker type 3 is in the 0 column, where there is a fracture with depression. There is pure articular depression in the lateral tibial condyle. Then 1 column fracture is Schettker type 1 and 2. The articular depression in the posterior column with the break of the posterior wall is also defined as 1 column. This type of fracture is not included in any type of the Schettker classification. So that's why the 3-column classification is very, very important. The 2-column type is Schettker type 4. In this, there is on concurrence of an anterolateral fracture and separate posterolateral articular depression with the break of the posterior wall. So there are 2 columns are involved. One is the lateral column, another is the posterior column. So the 3-column fracture is type 5 and type 6, Schettker type 5 and type 6. In this, at least 1 independent articular fragment in each of these 3 columns are present. Why we go for the 3-column classification? Because there is a very good research paper based on all the 3 classifications, and they have shown intra-observer assessment was very much similar, and it was very good, and it was acceptable to all. So that's why it can be very well practiced, it can be popularized. That's why 3-column classification is now in the vogue, and it is now very much popularized and very much used by most of the orthopedic surgeons. Sometimes there is a posterior shear fracture, and posterior shear fracture, it does not fit into Schettker's any of the classification, and it needs posterior approach for fixation. Sometimes there is only intercondylar eminence fracture, which is usually involving the cruciate ligaments avulsions. So next we come to the evaluation of the patient. As soon as patient comes to us, we should, besides taking the vital parameters and the other associated injuries, we should go for the examination of the part. In this physical examination, besides examination of the skin conditions and other things, we should always look for the neurovascular status, the compartment syndrome and the ligamentous injury. There is very, very important thing, because the tibial condyle fractures are very notorious for the compartment syndrome. So we have to be very much watchful for any of the blisters or any of the tense skin, any of the glossy skin. If there is, we should be alert that there may be some compartment syndrome is inevitable. Sometimes there is also ligamentous injury, so we should also look for the valgus stress test, varus stress test, the anteroposterior stress test, so that we can know is there any ligamentous injury or not. What investigation we should go for? The AP X-ray is very important, lateral X-ray is important, and oblique view. These three views are mandatory for any of the tibial condyle fracture to look into. Then stress radiographs sometimes are really required if the patient allows you. If the pain is not severe, then you can go for the stress X-rays also to know the ligamentous injury. But in minimally displaced fracture, local compression, this does not hold good. CT scan, it is the dictum in our department. Any of the intra-articular fracture of any of the joint, we need CT. CT gives us very good information about the displacement, about the placement of the various fragments, about the distance of the amount of displacement, whether it is 3 millimeter or more than 3 millimeter, whether the fragment is depressed or it is at the same level. And also it gives us good idea how to plan it, how to classify it, and how to manage it. MRI is usually not indicated, but sometimes those who have done the MRI, it's an important finding, and it's an interesting finding that in collateral ligament injury, there are 55% were there in collateral ligament injury. The lateral meniscus injuries was in 45%, and medial meniscus tear was in 21%, and PCL injury was in 28%. So what is the aim of the treatment? We aim at anatomically reduction of the articular surface. Mind it that anatomically reduction of the articular surface is mandatory, because if the joint surface is incongruent, then it is sure that it will lead to osteoarthrosis. Secure and stable fixation should be there, so that we can go for the early mobilization exercises. If the stable fixation is not secure, then it will lead to loosening of the plates and screws, and it will lead to the redisplacement of the fragments. The maintaining the mechanical axis, this is very important. If the fixation is in varus or the valgus, then it will lead to osteoarthrosis. The patient will be feeling difficult in walking. Another important is restoring the ligamentous stability and early and painless knee range of movement. It is very important, because if the patient is up and about at the earliest, then the patient is happy and the surgeon is also happy. Non-operative management, is it possible? Yes, it is possible. If the fracture fragments are non-displaced or minimally displaced, means it should be less than 3 millimeter displacement. Elderly patients, in such cases, we can go for non-operative management. What are the goals of surgical treatment? The surgical treatment, we aim at reconstruction of the articular surface, re-establishment of the tibial alignment, reducing and buttressing of the elevated articular fragments, soft tissue reconstruction. So we aim at early range of movement, adequate pain management, joint stability, and better functional outcome. So operative management, what are the indications? The indications are open fracture, lateral plateau fractures with articular step more than 3 millimeter, condylar widening of more than 5 millimeter, coronal plane instability is there, displaced medial tibial plateau fractures, bicondylar fracture, associated compartment syndrome. This is very important. If there is associated compartment syndrome, you have to be very watchful, and you should intervene at the earliest so as to prevent the further damage to the limb. And if there is associated vascular injury, you have to call your vascular friend also to see whether we can save the limb or not. What operative management, the absolute indications are open fracture, compartment syndrome, and vascular injury. These are the three main indications. But the relative indications which we usually do is most displaced bicondylar medial condyle fractures, lateral plateau fractures with joint instability, condylar widening that exceeds 5 millimeter, fracture dislocation of the knee, and polytrauma patients in which you need early mobilization of the patient. In operative management, what should be the implant and what should be the approach? This is very important. If the implant is not proper, if the approach is not proper, the fixation will not be good, and the overall result will be zero, and the surgeon and the patient will be unhappy. So the implant options can be rod fixator, ring fixator, hybrid fixator, conventional plates, and the least invasive stabilization system. The approaches can be lateral approach, it can be anterolateral approach, it can be medial or the posteromedial approach, it can be posterolateral approach, it can be dead posterior approach, or it can be a combined approach as well. So these are the pictures we should look for always. If these are the blisters, these are the skin, this is the skin condition of the limb, you should be very scary, you should be very careful. In such cases, when the skin condition is not good, it is showing the many blisters, then the best system of stabilization is the external fixator or the rod fixator or the ring fixator or the hexagonal fixator or the limb joint spanning fixator, whatsoever it is. But you should always go for such fixators, not the internal fixation. So these are the safe zones of pin insertion. If it is above the tibial tuberosity, then these are the three areas where you can pass the pin. If it is below the tibial tuberosity, then you can pass these two areas. If it is in the middle of the leg, these are the two areas where you can pass the pin. And if it is at the ankle level, these are the two areas where you can pass the pin. So Schettker type 1 fracture. Let us see the management, how we can go for management of these different types of fractures. In Schettker type 1, the non-operative management can be done. The coronal stabilizing brace with knee range of movement can be given. The patient should be non-weight bearing and he should be given some analgesics and knee mobilization exercises. The operative cases, in such cases, if the patient is young, if he is high demand patient, then you can go for percutaneous fixation and early range of movement exercises. One partially and one fully threaded screw is sufficient in such cases. But if the bone stock is poor, then you should go for plating. So Schettker type 2 fractures. In such cases, there is a depression in the lateral condyle. So you should go for open reduction and elevation of the depressed fragment. This is very important. If the depressed fragment is not elevated, the limb is, the knee joint is unstable and it will lead to osteoarthrosis. So after reduction, after properly seeing the depression is completely elevated, then the defect should be filled with the autografts or the bone substitutes, and then it should be fixed with the raft screws and anti-glide plates. Schettker type 3, again, there is a split as well as the depression. And in this case, again, you have to go for complete elevation of the depressed fragment either through anterolateral approach, and then you fix it with some K wires or something like, and then fill the defect with the bone graft or the augments, and then final fixation should be done with the subchondral raft screws and an anti-glide plate. Schettker type 4, this is the fracture of the medial condyle. This anteromedial approach should be taken. Fixations with medial buttress plate should be done. The counteract the shear forces acting on the medial plate too, so that, and then leg screw alone is not sufficient. So always go in the medial condyle fractures, such fractures, you should go always with the plate on the medial side. Otherwise, there will be shear forces and the medial condyle will again displace downwards and medially. Schettker type 5 and 6. This is the most complicated fractures. In this case, the fixation plan and approach is to be decided as per 3-column classification on the CT scan. And it requires lateral and the medial stabilization of the fracture. This is an important thing. In type 5 and type 6, Schettker type 5 and type 6, you require medial as well as the lateral stabilization. It will not hold if you go only for the lateral stabilization or the medial stabilization. So stabilization can be done by double plating, by locking plate or external fixators. So what are the approaches? Let us go for the approaches. This is the lateral approach. We have to identify the Gerdy's tubercle, make a straight incision 5 centimeter in length, starting posteriorly to the Gerdy's tubercle and running distally and anteriorly. This is direct lateral anterolateral approach. Make a straight incision lateral to the patella and then open the deep fascia anterior to the IT iliotibial tract, identify and isolate the lateral meniscus, and then you can open up and you can do the fixation. The medial approach or the posteromedial approach. In this case, the knee is in slight flexion. You can put a bump on the in the knee, under the knee joint, make a straight and or slightly curved incision from the medial epicondyle towards the posteromedial edge of the tibia. It can be extended, the incision can be extended both proximally as well as distally. And for the posteromedial fixation, deep dissection is required, which is posterior to the pes anserinus through semimembranosus and medial head of the gastrocnemius interval. The posterolateral approach. The posterolateral approach can be through femoral epicondyle osteotomy, fibular resection osteotomy, digastric fibula head osteotomy, or the posterolateral Frosch or the Frosch approach. This is the femoral epicondyle osteotomy. The screen towards this is the proximal part, this is the distal part, this is the medial part, this is the lateral part, this is the medial, this is the femoral epicondyle, lateral epicondyle, which is being osteotomized. And after osteotomy, you can see the joint line is visible here, and you can fix the fracture fragments very well, easily. Again, this is the proximal part, this is the distal part, this is the fibula which is being resected over here. This fibular head is being resected, it is completely resected. So in this, after resection, you can see the joint line very well visible here, and you can approach the fracture fragments very well from here. So digastric fibula head osteotomy. In this case, you can osteotomize the fibula along these lines without damaging the common peroneal nerve. This is the incision starting from the crest of the tibia, moving upwards laterally and posteriorly up to the joint, just above the joint line. Okay, this incision is good enough for exposing the lateral part of the tibial condyle through the digastric fibular head osteotomy. In this case, this is the osteotomy site. The head of the fibula is being osteotomized in this way, and after osteotomy, the fracture fragments are very well available. This is joint line, this is the lateral collateral ligament, and this is the lateral fibular head osteotomy. And this way you can fix the fragments. And this is the meniscus. This is the meniscus, and this is the lateral collateral ligament. This is the joint line here. You have fixed the whole of the fragments very well. It is a stable fixation. The posterolateral approach or the Frosch approach. Whatsoever three approaches I have described you, that was all in the supine position or in the figure of 4 position. But this posterolateral approach or the Frosch approach is always in the prone position. This is the biceps. This is the prone position. This is the popliteal region, and this is the biceps femoris tendon going laterally. This is the common peroneal nerve along with the biceps femoris tendon. This is the lateral gastrosoleus, and this here it will come the medial gastrosoleus. And after exposing through the lateral gastrosoleus, this is the joint line visible very well, and you can see the posterior part of the tibia, which is visible to you. And through this approach, you can fix the posteral lateral implants over there and fix the fragments over there. This is the dead posterior approach. This is a curvilinear incision through the popliteal fossa. In this case, this is the tibial nerve, this is the common peroneal nerve, and you have retracted it. And then this is the medial gastrosoleus head, and this is the joint line. This is the through this you can approach the posterior fragments, and you can fix very well the fragments. So after achieving this fixation, we have to take care of the complications. What are the complications? One is the most important one is the infection, which is present in 3 to 38% cases. What I feel is the infection depends on the 3 factors. One is the factors related to the patient, the factor related to the surgeon, and the factor related to the OT environment. So you should have the control over all these 3 factors. Then the chances of infection are very less. So another complication is thromboembolic complication, and the late complication can be painful hardware, loss of fixation, post-traumatic arthritis, and the malunion. So take-home message. What I feel in my experience of around 38 years of experience, I feel that whenever a patient of the tibial condyle fracture comes to you, you should spend more time in classifying and assessing the fracture pattern on the X-ray as well as the CT, because the planning is very important in this case. Never underestimate the soft tissue injury. Always keep external fixation options ready in your theater, because you don't know, you are not able to fix the fragments properly, then you can go for the external fixation. Choose your approaches wisely as per the fracture pattern. Keep an eye on post-op complications and be attentive to for early intervention. Thank you very much for patience listening.